So a very good afternoon, everyone. Um, yes, so I'm not a clinician. I'm a basic scientist. And I've been asked to talk about what should a clinician know for interpreting an NGS data. But before getting into the interpretation, what I wanted to today elaborate on specifics of when should you really go for an NGS kind of a testing. So that I would kind of start with the liquid biopsy. And once we are done with the liquid biopsy, and should the time permit, I would also want to go for the solid biopsy. Starting with the basics, the liquid biopsy, as what we are aware of, primarily, whether it may entail the CTCs, the circulating tumor cells, or the exosomes, or the ctDNA. That's the cell-free DNA. So today we will restrict ourselves to the cell-free DNA. And essentially what you really need to know, which is something which is very paramount in these kind of settings, is that the ctDNA is highly unstable. It has a very rapid turnaround time. So this turnaround time is actually an equilibrium of the dynamics between its generation and the degradation, as you are aware of. So what is very critical when you're going for a liquid biopsy per se is that the timing of when you are going for the liquid biopsy. And what we know is that the positive predictive value, that if an alteration turns out to be positive in the liquid biopsy, is high. However, what comes along in the same package, that the negative predictive value is extremely low. So what it may entail is that you are getting a report which turns out to your office as a negative report, but that may not be reflective of the tumor or of your assessment of the patient's underlying disease, and to minimize that negative predictive value, we have to understand what underlies it. And that's something that I wanted to kind of emphasize. I wanted to emphasize on three different aspects: technical aspect, biological aspect, and the clinical aspect associated with, and what that would kind of like lead to minimize or better understanding of who should really qualify for the liquid biopsy. So not every, I mean, this is something and a statement that I cannot emphasize enough. Not every patient is qualified for a liquid biopsy. In fact, what I'm showing over here, I would like to point your attention to in this specific study on metastatic colorectal cancer. My pointer is not working. Please look it towards your right. It appeared that about 50% of the patients did not require the liquid biopsy or did not qualify the basic benchmark for the liquid biopsy. And why is it so? It was so because the CT fraction, that is the ctDNA fraction in these folks, were less than 1%. So how do we know that whether a patient would really have the requisite underlying CT fraction or not is something which is paramount and should be in your consideration for prescribing these tests. And just to give you an example, somewhere in the center, what we have over here on the x-axis running from left to right is the increasing ctDNA content in the patients, in the plasma of these guys. And what you're seeing somewhere in the middle region where the CT fraction is between 1 to 5. Now, this is the range that you would really want to target. And that's very important, because if your CT fraction is lower than 1%, then majority of the times that the data, and I have never seen, very few reports that comes out back to your office where the service provider has really enumerated or underlined that what was the ctDNA fraction. If the ctDNA fraction was under 1%, then majority of the data that what you have received is erroneous, and that would not be reliable. And for example, as what is shown over here with your limit of detection with regards to the point mutation, and more so for the copy number alteration, and that's shown around over here. Here there is a direct comparison between the primary tumor and the liquid biopsy, and what we see over here, that here the copy number alteration appears to be completely lost. There's a homozygous deletion. Actually, it was not a homozygous deletion. This was coming out to be so because the ctDNA fraction of these folks were under 1%. So what are the variables that kind of like underlies this? We will get into that, but I also wanted to emphasize over here is that why is it very important? I mean, just to take a small mathematics detour, ideally you would be prescribing, ideally you would be taking about a 10 ml of blood. Now 10 ml of blood would essentially have, that would correspond to 10 nanogram of ctDNA. Depending on several other different factors, but that's an average, that what you kind of like an estimate about. Now we know that the human genome, the haploid human genome, that is the genome in the gametes, that is just half of your whole genome, is about 3.3 picograms. Now, if your human haploid genome is 3.3 picograms, then in the 10 nanogram of your DNA, there will not be more than 3,000 copies. Now, if you are having 3,000 copies of haploid genome from a 10 ml blood, if you are wanting to look for at least 3 reads of your variant allele, of your mutant allele, then what essentially would require is your determination, the limits of determination and estimation should be somewhere around the fraction of 0.1%. Now, you would find a report coming back to your office in which they would talk about that the variant allele fraction is 0.01%. Now, you need to be very cautious of that fact. How can it be 0.01%? For 0.0%, there is only 2 ways that it could be possible. Either you have taken 100 nanograms of ctDNA, that means you went around for 100 ml of blood, which is not possible, or otherwise this would just not be deterministic at all. So anything in that range, depending on what would be the limit of detection of the service provider, your allele fraction, if it is below 0.1% and at least 3 reads are not been read, is something again creates a sense of doubt. These were the technical aspect to it of the liquid biopsy. I'm just giving you an overview of it, a bird's eye view, but I will be happy to talk in detail should there be any interest. Let's change gear and let's look into the biological aspect to it. Even biologically, we know that not all the tumors or not all the patients would qualify for the liquid biopsy. We all know about the classical studies which has also been done at the TMH and across the globe, where the increasing stage has a direct bearance on the increasing ctDNA content. We know that the stage 4 folks will have a higher CT content. It's not only the staging, it's also the tumor type, just like the mutation tumor burden. Time is up. 1 more minute. Sure, maybe 2 minutes, I'll just wind up. So we know that the bladder cancer would have a higher ctDNA and any of these GBMs and all, where the barrier would be an issue, the ctDNA content would be inherently low. Not just the blood, there are several different that are very frequently being utilized in the clinics. They cannot be used for liquid biopsy. They cannot be used for liquid biopsy unless you are just going after a single alteration, because the amount of ctDNA in any of these would be way too far less and insignificant that would allow you to go for any of those panels. Now that's a different thing, that if you're only looking for EGFR or if you're only going after one specific alteration. I will cut it down. Other aspects were as what the stage we talked about. If the primary tumor is intact, then the ctDNA value would be higher. Of note, even in the metastatic side, where exactly the metastasis has happened, that's important. If it is there in the liver, the ctDNA content is going to be higher, and whether it is restricted to the peritoneal cavity or So another important thing that in the liquid biopsy, very frequently we tend to get about, and this is kind of like unfortunate, that the DNA repair alterations, those mutations which are involved in DNA mutations because of the clonal hematopoiesis, you get a JAK2 mutation. So you have to be cautious, you have to know about it, and it does not take too much of an effort for you to go back, I mean not for you, for the service provider to give it back to you, that whether it is really coming from the germline or not. You are spending huge amount of money for the liquid biopsy. If you take the PBMCs, just the white blood cells, and if you do a low pass sequencing for hardly few thousand of rupees, you would get to make a distinction what's a germline and what's not. This is not being done in the liquid biopsy, but that is for the fraction of the cost, and without an additional cost. Most likely, if you get these kind of like alterations, you would. The clinical aspect associated with the CT fraction is that we know that at the baseline, if the CT fraction is higher, and on therapy, if there is a complete whole disappearance of the CT fraction, or if it's not, that has a strong clinical connotation, or the survival probability that is associated with it. And I wouldn't even kind of like want to emphasize onto that. Not only the prognosis, even the prediction is affected, that when the relapse is happening and what different kind of like alterations. I'm just going past, sorry for that. So what should we do? So we need to know what test to order and for whom. We are going for the stage guys, different stage tumors. We are going for in the pre-cancer settings. So we have to order accordingly. While we would require a higher sensitivity over here, we would require a still more higher sensitivity if you are in the earlier stages. And this is what my focus, my laboratory at University of Delhi, Department of Genetics is going to be focusing on. We will be working significantly on the early diagnosis and on to the biology of ctDNA and increasing the higher sensitivity of it. And what goes inverse with the sensitivity is is the kind of number of genes that you would really want to interrogate. If you are wanting to interrogate a large panel, then do not think about the times that or when you're going for something such as an MRD determination, that cannot be done because that would require a super high sensitivity. And that can be done on few genes. If you're going for a larger panel, then that has to have a lower sensitivity, or there has to be a compromise in the size of the genome that what you're integrating. So this inverse correlation has to be kind of like taken. I wanted to take you through the dynamics of ctDNA, but I would go past through it. I would rush through it. I would go past all of my slides. 10 minutes was inadequate for me, and that was my fault. I thought that I would be able to cover. I wanted to kind of like let you know, and this is a thought for your process, that now I'm coming to the general NGS report, that you talk about that there are variants that you do not understand because those variants are variants of unknown significance and all. But the context of that is way too far more important than that. I would have detailed about the variants of unknown significance, but I want you to take this, that even the driver alteration is contextual. If the driver alteration is being found in the blast phase of CML, then perhaps it's not druggable. What is important, and I wanted to draw your attention, is that the driver alterations such as ARID1A, PIK3CA, KRAS are associated with endometriosis, and which has nothing to do with endometrioid cancer. And lo and behold, their VAF, I couldn't talk about today, I wanted to emphasize on, their VAF is significantly high. Now, so these are driver alterations at a high VAF, but still they are not associated with cancer. They are not targetable at all because nothing can be done about it. You look at the synovium of the patients, you will find a high P53 mutation alterations associated in the rheumatoid arthritis. What are they doing over there? BRAF mutation, we know about the melanoma. 80% of the benign nevi are associated with V600, one of the very activating alterations. ERB2 alterations are known to be more associated with DCIS as compared to the invasive. So it's all about the context And it's all about understanding the biology of your patient, of the tumor of your patient, and then making an informed decision. That is what is required. So having a multidisciplinary molecular tumor board is something that I really cannot emphasize enough upon. There are things which is beyond what a clinician would want to enter into, and that's why having people from across different would be something that would be the way to go, not to mention the BRAF mutations, which are different in different cancers. So with that, I bring into my talk, but I will be happy if to bring in more granularity and more specific, if should there be question, if the time permits, with the chair permission. Thank you.
Thank you, sir, for that very enlightening talk.
Good afternoon.